Good morning, everyone. My name is Matthew Anderson. I'm a third year plastic surgery resident, and I'm going to be talking about wrist arthritis. Um, just to begin, some general background information and considerations for the patient with wrist arthritis. Wrist arthritis, very common, affecting approximately 13.7% of the US population. This is most commonly post traumatic in nature. Primary osteoarthritis of the wrist is actually relatively uncommon. In rheumatoid arthritis patients, over 50% have wrist involvement at 2 years from diagnosis, and this number increases to 90% at 10 years. So, wrist arthritis can be broadly classified based on the underlying mechanism. Degenerative, which refers to primary osteoarthritis, post-traumatic, which typically results in a predictable pattern of arthritic change. This includes SLAC, SNAC, and DRUJ arthrosis. Inflammatory wrist arthritis, such as in RA, psoriatic arthritis, and even lupus. There are congenital causes, such as Madelung's deformity, idiopathic, as in Kienbach's and Pricer's, crystal-induced arthritis such as CPPD and gout, and reactive arthritis. So, pathophysiology of osteoarthritis in particular, excessive or abnormal joint loading stimulates joint tissue cells to produce pro-inflammatory cytokines. These cytokines lead to a cascade of proteolytic enzymes such as MMPs and proteinases that are ultimately responsible for ECM degradation, resulting in cartilage destruction. Wrist arthritis, at least for the hand surgeon, is typically thought of based on the location of disease. There are various patterns which, as I said before, follow a predictable progression. SLAC wrist, SNAC wrist, STT arthrosis, DRUJ arthrosis, and Ulnocarpal abutment syndrome, PT arthrosis, and rheumatoid wrist. So it's always important in a patient presenting with chronic wrist pain or established wrist arthritis to obtain a good clinical history, especially the symptoms that brought them in to see you in the first place. Typically, this will be pain, crepitus, swelling, decreased range of motion, weakness, decreased grip strength. It's important to identify the exact functional impairment that is a result of their pain. This is especially important because it can key the surgeon in on when to intervene surgically. Prior traumatic injuries, prior fractures, important to get a history for. Any underlying systemic disease or comorbidities. And then occupational and functional demands are important to note, as this often will lean the surgeon one way or the other as far as which procedure to pursue. So physical exam, obviously, good, complete, thorough hand exam is important. This includes a complete motor and sensory exam. Visual inspection is particularly important and can clue the surgeon into underlying etiologies, paying particular attention to scars, swelling, effusion, deformities, any masses or ganglia. Important that the surgeon assesses range of motion, grip strength. You can often use loading to localize points of maximal tenderness. Various provocative maneuvers are available and have been described for different locations of um, suspected arthritis. And it is important to assess instability of any wrist joints. This is particularly important for scaphoid and the DRUJ. So imaging in wrist arthritis really hinges on dedicated wrist radiographs. These include a PA, lateral, and oblique, sometimes also clenched fist. There are specific joint views that are available based on the joint in question. CT and MRI are used not commonly, but CT specifically can be used to better evaluate bone quality and joint disease, whereas MRI can be used to evaluate vascularity, any changes in the bone marrow, pathologic soft tissue conditions, and can also better delineate joint disease. So non-operative management is really the cornerstone of early management of wrist arthritis. It's almost always the first line of treatment, especially in mild to moderate disease. Typically, it consists of the same basic categories of rest, heat, which can be achieved with submerging the hand and wrist for 10 minutes twice a day in warm water or wax. Pain medications such as Tylenol, NSAIDs, Voltaren gel, splinting and hand therapy also play a role, specifically nocturnal and resting splints. And then hand therapy consisting of exercises working on range of motion and also activity modification. Corticosteroid injections are particularly useful as they can be diagnostic as well as therapeutic. So operative management of wrist arthritis, generally for patients who fail non-operative management, considerations for patients undergoing surgery, age, hand dominance, occupation, functional demands and limitations, contralateral involvement, and control of any underlying systemic disease. Basic principles: manage each involved joint. Typically, this results in predictable pain relief. Patients need to know that they're trading variable losses of strength and motion for pain relief. And then the surgeries typically include variations of resection arthroplasty, implant arthroplasty, and partial and total arthrodesis. So the first pattern of degenerative arthritis that I'm going to discuss is scapholunate advanced collapse, or SLAC wrist. So SLAC is a pattern of degenerative arthritis that is seen in chronic dissociation of the scaphoid and the lunate. Chronic SL ligament injury eventually leads to a DISI deformity with flexion of the scaphoid and lunate extension. On wrist radiographs, the SL angle is typically over 70 degrees. The lunate can be extended past 10 degrees of neutral. And then this results in a predictable progression of arthritis that starts at the radioscaphoid joint and eventually progresses to involve the capitolunate joint. Notably in SLAC wrist, the radiolunate joint is spared, although this is very hotly debated. So presenting symptoms in SLAC wrist, very similar to the other wrist arthritides, difficulty with weight bearing across the wrist. SLAC patients can have pain in the region of the SL interval. Progressive weakness and stiffness are also very common. On exam, these patients can have tenderness dorsally over the SL ligament, decreased range of motion of the wrist, reduced grip strength, and they can also have a positive Watson scaphoid shift test. This is primarily only an early stage disease, as the progressive arthritis typically stabilizes the scaphoid in late stages. So imaging really hinges on the Watson classification. Stage 1, as we said earlier, arthritis that is localized between the scaphoid and the radial styloid. Progression to stage 2 disease involves the entire scaphoid facet of the radius, as you can see in these pictures here. Stage 3 disease also involves capitolunate arthritis, and then the hotly debated stage 4 disease is arthritis of the radiolunate joint. So operative treatment of SLAC really depends on the Watson classification. Radial styloidectomy, this is indicated in stage 1 disease and can also be performed prophylactically in conjunction with other operative techniques. It is important in this procedure to preserve the radial sensory nerve and the volar RSC ligament attachments. Open and arthroscopic techniques have been described and this typically involves either a short oblique, vertical oblique, or a horizontal osteotomy. PIN and AIN denervation is also an option for stage 1 SLAC wrist. It's often combined with other procedures for more advanced arthritis. It involves denervation of the distal branches that provide sensation and proprioception to the wrist capsule. In the clinic setting, a bupivacaine block can be used to simulate for the patient the expected pain relief that would result from the procedure. And access to both nerves is via an incision 3 to 5 centimeters proximal to the dorsal wrist, as you can see in the photos over here. Proximal row carpectomy is an option for stage 2 SLAC. It is contraindicated in stage 3 disease and in incompetence of the RSC ligament. This is because the RSC ligament prevents ulnar subluxation and volar dislocation of the carpus following the procedure. The procedure involves excision of the scaphoid, lunate, and triquetrum, and notably, long-term outcomes for PRC have actually been shown to be inferior to four-corner fusion in heavy laborers and in patients under 40 years of age. Scaphoid excision and four-corner fusion. This is an option for stage 2 and 3 SLAC wrist. It involves fusion of the lunate, triquetrum, capitate, and the hamate. Wrist range of motion is preserved due to the articulation that remains between the lunate and the distal radius. It is important during scaphoid incision to preserve the volar RSC ligament. During the procedure, the joint surfaces that are going to be fused are decorticated, and the fusion bed is filled with autologous bone graft. There have been various fixation techniques that have been described, including K-wires, screws, staples, and circular plates. Patients need to know beforehand that this procedure requires prolonged immobilization. Some patients either don't want to or just can't tolerate prolonged immobilization, and it can definitely play into their decision making. Total wrist fusion, this is indicated in stage 3 SLAC wrist, pancarpal arthritis, and also as a salvage procedure. It is the most reliable pain relief, but obviously at the expense of wrist range of motion. In the procedure, the articular surfaces of the radiocarpal, midcarpal, and the third CMC joint are denuded and filled with autologous bone graft. Following this, generally a pre-contoured compression plate is used to span the dorsal radius and the third metacarpal. And then notably, post-operatively, as high as 10.5% of patients that undergo total wrist fusion will develop carpal tunnel syndrome. So it's important to rule out any pre-existing carpal tunnel syndrome prior to fusion. Total wrist arthroplasty. Indications for total wrist replacement are late stage SLAC, specifically in elderly low demand patients. It's also useful in certain instances of failed limited arthrodesis, and also has some benefit in avascular carpal necrosis. As I said earlier, careful patient selection is very important in patients considering total wrist arthroplasty. Various implants are available. Various manufacturers produce these implants, all of which vary somewhat. The procedure typically involves excision of the proximal row, the proximal scaphoid, and a portion of the triquetrum. Post-operatively, patients can generally anticipate around 40 degrees of extension, 20 of flexion, and 10 to 15 of radial and ulnar deviation. So the next pattern of degenerative arthritis that I'm going to talk about is SNAC, or scaphoid non-union advanced collapse. So SNAC wrist, is a progressive pattern of degenerative arthritis that results from chronic scaphoid non-union. The degenerative change, similar to SLAC wrist, begins at the radioscaphoid articulation and is followed by pancarpal and midcarpal arthritis. The prognosis in SNAC wrist is worse in patients who have non-unions greater than 5 years and also in proximal pole necrosis. So the presenting symptoms of SNAC wrist, again, very similar to SLAC: reduced grip and pinch strength, reduced extension and radial deviation, progressive wrist pain and instability. On physical exam, these patients can have localized tenderness over the radioscaphoid articulation and reduced wrist extension and radial deviation. So imaging for SNAC, as I said earlier, very similar to SLAC wrist. Stage 1 arthrosis is localized to the radial side of the scaphoid and the radial styloid. Stage 2 has the progression to scaphocapitate articulation, and stage 3 involves periscaphoid arthrosis, which progresses to the capitolunate joint. Operative management of SNAC wrist is similar to that of SLAC. Radial styloidectomy is an option in stage 1 SNAC. This is generally not performed as a solo procedure and is instead usually combined with procedures that will address the scaphoid non-union. Distal scaphoid resection arthroplasty, indicated in stage 1 SNAC. This is technically simple with a high patient satisfaction rate. Provides patients with significant improvements in range of motion, grip strength, and pain, with generally durable results. Does not preclude other later salvage procedures, which can be very important in these patients. Proximal row carpectomy, indicated in stage 2 and 3 SNAC, with minimal to no capitolunate disease. Scaphoid excision and four-corner fusion, again, stage 2 or 3 SNAC. Total wrist fusion, later stage disease, pancarpal arthrosis, and again as a salvage procedure. So the next pattern of degenerative arthritis I'm going to talk about is STT arthritis. So STT arthritis is actually the second most common location of wrist arthritis, and it has been reported to affect up to 16% of the U.S. population. There's a strong association with CPPD and also a strong association with basilar thumb joint arthritis. It results from instability of the STT joint or within the carpus, such as DISI deformity or midcarpal instability, and leads to cartilage erosion and the subsequent development of arthritis. So presenting symptoms similar to other wrist arthritides: reduced grip strength, pain. In these patients, actually, the wrist pain can be described as being sharp, especially with gripping and radial deviation of the carpus. FCR tendonitis can also be seen in these patients. On physical exam, they can have a painful bony prominence that's just distal to the radioscaphoid joint. Range of motion, notably, is often preserved in STT arthritis. And they can have pain along the STT articulation, especially with wrist deviation. So imaging of STT arthritis, obviously you want to obtain standard wrist radiographs. Imaging should also include STT views with the wrist in full ulnar and radial deviation. You'll see typical findings of osteoarthritis, joint space narrowing, osteophytes. There's numerous classification systems that I found. I'm not sure if any of them are consistently used. I included one here, the white classification, and I apologize, one of my pictures got shifted. So operative treatment of STT arthritis, one option is the excision of the distal pole of the scaphoid. This is generally for patients that desire preservation of range of motion and those that are not amenable to prolonged periods of immobilization. It involves the excision of the arthritic articulation via either a volar, dorsal, or arthroscopic approach. The void that's left behind can then be filled with a tendon interposition. And notably, this procedure has the potential to develop or worsen any pre-existing DISI deformity. STT fusion, generally recognized as the procedure of choice in STT arthritis, particularly ideal in young patients and heavy laborers with high functional demands. It is contraindicated in pre-existing radioscaphoid arthrosis and is less ideal if the scaphoid is highly mobile, which is the impetus for the radial and ulnar deviation views. This procedure is often combined with a radial styloidectomy due to the risk of postoperative impingement at the site. And various fixation techniques have been described, including K-wires, compression screws, staples, and circular plates. Pyrocarbon implant arthroplasty is also an option for STT arthritis. This involves a scaphoid trapezial interposition implant that is placed following distal scaphoid resection. It is important when using this implant to preserve the ST and SC ligaments. Otherwise, this could lead to a DISI deformity, and notably is contraindicated in the presence of concomitant basilar joint arthritis. So the next progressive pattern of arthritis that I'm going to talk about is DRUJ arthritis. So common causes of DRUJ arthritis are following trauma, such as after a distal radius fracture. Inflammatory arthritides commonly involve the DRUJ. Ulnocarpal abutment syndrome can also lead to DRUJ arthritis. The presenting symptoms, similar to other wrist arthritides, pain, stiffness, swelling, decreased grip strength. On physical exam, there's typically point tenderness over the DRUJ. Pain is usually exacerbated by forearm rotation and joint compression. And you can also see DRUJ instability and crepitus. Imaging in DRUJ arthritis. Early radiographic findings typically occur at the proximal joint and tend to spare the sigmoid notch. Osteophytes can often be seen and are located along the proximal ulnar head. You can see evidence of distal radius fracture non-union or malalignment, and ulnar positive variants can also be seen. Ulnocarpal abutment syndrome. This is a common cause of ulnar-sided wrist pain in patients, secondary to impact stress between the ulna and the lunate. It is associated or a result of positive ulnar variants. This can be seen in SL dissociation, TFCC and LT ligament tears, and radial shortening from a previous radius fracture. Radiographic findings include, of course, positive ulnar variants, and then the resultant sclerosis of the lunate and the ulnar head. Operative treatment of ulnocarpal abutment syndrome is generally similar to that of DRUJ arthritis. So operative treatment of DRUJ arthritis, one option is the hemiresection interposition arthroplasty. This involves the removal of the articular surface of the ulnar head while maintaining the TFCC and the ulnocarpal ligaments. It's a procedure that is intended to address the instability associated with the Derrick procedure. Either local tissue, muscle, or tendon can be used for the interposition following resection. In this procedure, caution should be used in ulnar-carpal translation, positive ulnar variance, and irreparable TFCC damage. The Suave-Kapanji procedure, this involves DRUJ arthrodesis with a resection of a portion of the distal ulna and creation of a proximal pseudoarthrosis. It's an ideal procedure in patients with rheumatoid arthritis as it's proposed to prevent ulnar translation of the carpus. Various fixation techniques have been described, including cannulated screws, K-wires, and then FCU tenodesis can be used to stabilize the proximal ulnar stump if needed. The Derrick procedure, or distal ulnar resection. This is a procedure that's been performed for a long time, especially in rheumatoid arthritis. It's ideal for low demand patients with severe DRUJ incongruence and also in ulnar impaction syndrome. In the procedure, a transverse osteotomy is made at the proximal margin of the sigmoid notch. Following this, a subperiosteal dissection is done to free the distal fragment, which then subsequently allows for closure of the periosteum. There are various procedures that have been described for stabilization of the proximal ulnar stump, including using FCU, ECU, and PQ. Ulnar head implant arthroplasty. This is an ideal treatment for radial ulnar impingement following a failed partial or complete distal ulnar resection. There are various implants that have been described, various techniques. Here's some radiographs and pictures displaying a few of them here. You can see the obvious differences in the implants that are available. For DRUJ arthritis, the absolute salvage procedures are one bone forearm and wide ulnar resection. In one bone forearm, this is a salvage option, which involves fusion of the radius and the remaining proximal ulnar stump, as you can see in this picture here. It results in predictable pain relief, but of course at the expense of complete loss of forearm motion. Wide ulnar resection, couldn't find any pictures of this one, but it's also a salvage option, which involves a subperiosteal resection of 25 to 30% of the total ulnar length. It's contraindicated in patients or in previous traumatic disruption of the interosseous membrane. PT arthritis. So this is relatively uncommon. Particularly, it's possible that it's uncommon because it's underdiagnosed. The joint space of the PT joint is not well seen on standard radiographs. Instead, it's best visualized with the wrist in 30 degrees of supination. As you can see in this photo here, you can clearly see the joint. These patients typically present with chronic ulnar wrist pain, and then operative treatment consists of pisiform excision in cases that are refractory to non-operative management. So rheumatoid arthritis, the pathophysiology of RA, a synovial antigen is theorized to trigger immune cells. A pro-inflammatory response ensues, primarily driven by TNF-alpha and IL-1. This results in a cascade of MMPs, collagenases, cathepsins that are produced by the synovium. The result is a thickened, inflamed synovium, referred to as a pannus, which subsequently erodes cartilage, subchondral bone, and weakens the supporting soft tissues. So in rheumatoid arthritis, DMARDs have significantly reduced the need for reconstructive hand surgery over the past few decades. In these patients, you almost always want the patient to have undergone at least 6 to 12 months of medical management prior to any operative intervention. indications for surgery, functionally limiting and painful deformities that are unresponsive to conservative management. The general priorities of hand surgery in rheumatoid arthritis: number one, treat painful joints. Number two, improve function. It's important to note, or important to be sure that patients understand that the goal is not to restore function, at least their previous level of function, but improvements can be made. Number three, slow the progression of the disease or prevent loss of function. And then number four, lastly, improvement in appearance, although patients should understand that this is never an indication for operative intervention in rheumatoid arthritis. So wrist disease in RA typically progresses in a very predictable pattern. The most early sites of involvement in the RA wrist are at the scaphoid waist, the ulnar styloid and head, and the radiocarpal ligaments. Characteristic deformities result: caput ulna syndrome. This is dorsal distal ulnar prominence, which you can see in this photo here. This leads to carpal supination and ECU subluxation. Scaphoid instability and rotatory subluxation are also common. Ulnar and volar carpal translation is kind of a hallmark of the rheumatoid wrist, and then ensuing loss of carpal height, particularly secondary to scaphoid instability. So, treatment of the rheumatoid wrist: synovectomy of the radiocarpal joint and the DRUJ. This is considered a preventative procedure if done early in the disease course, but is often combined with other procedures in later stages. This can be done via a dorsal approach. Access to the dorsal wrist joint and the DRUJ is possible via this approach. It's typically combined with dorsal tenosynovectomy. A volar approach has also been described. It involves volar wrist synovectomy and is, again, typically combined with flexor tenosynovectomy. So DRUJ involvement in RA, the management similar to non-inflammatory arthritis that we just discussed. Distal ulnar excision, particularly with DRUJ reconstruction and TFCC, either preservation or reconstruction. This is important because it allows correction of the carpal supination and stabilizes the distal ulna. The Suave-Capangi procedure. Some people theorize that this is actually a superior procedure to the Derrick, primarily because it supposedly prevents ulnar translocation and is therefore of particular use in rheumatoid arthritis. There's a couple pictures here of DRUJ reconstruction and preservation of the TFCC. Radiocarpal reconstruction in RA. This can be done by either partial or total wrist arthrodesis. Radiolunate arthrodesis. This is indicated if there's preserved articular surface of the scaphoid. RSL arthrodesis, in contrast, is indicated in complete proximal row involvement. And here's a couple examples here: staples being used, compression screws. Radiocarpal reconstruction in more advanced rheumatoid arthritis. Total wrist fusion is an option. This can be done by either plates or IM pins. Significant deformity and instability, advanced joint destruction, poor extensor function, and poor bone stock are indications for this procedure. Total wrist arthroplasty is also actually a good option in rheumatoid wrist, especially in those patients that seek preservation of wrist range of motion, particularly if they have more proximal joint involvement in the extremity. And that is all I've got.